introduce myself. I am Robert Poston. I'm the Chief of Cardiac Surgery. I just started in January. So I'm giving my 100-day report here. I've been here 100 days, and we'll provide you an update what's been going on with robotic coronary surgery, and then in collaboration with Dr. Schurlip and others in the cardiology division, talk about the hybrid procedure, which I think is one of the most interesting ways of pursuing this technology, because it really does provide the best of both worlds, the surgical longevity with the minimally invasive nature of catheter-based techniques. Really, the impetus behind all of this is to try to provide patients with disease that would traditionally be treated with the traditional approach, the sternotomy, the bypass machine, cardiac arrest, and these types of things, with another way. Doesn't mean that it's for everybody, doesn't mean that if you're a candidate for it that you should have it or you're an evil person. It just means we want to provide them with another option. And if they're candidates for it, they should know about that. That should be their right to know about it. Nobody should undergo a sternotomy in Tucson if they are a candidate for robotics for the mere fact that they didn't hear about robotics. It's perfectly fine that they undergo a sternotomy if that's what they choose. The reason why this is important to mention to patients is because of the following advantages that are relevant to them. Cosmesis, if you look at the sternal incision, typically much more overt in terms of its appearance on your chest as compared to a mini thoracotomy here, which it's about a 2-inch incision in between the fifth intercostal space. Another example of the incisions that we're able to do. These incisions here are for the robotic instruments, so that's what enables us to be able to do this without a sternotomy, is that we use a robot. We actually deflate the left lung. We put the robotic instruments into the left chest. Now that the left lung is deflated, we have room to work. The heart will drop away from the chest a little bit when the lung is deflated, and then we add CO2 insufflation, pushes the heart away a little bit more, and that gives us working space, and we are able then to do this operation inside the chest and not have to open up the chest and do it that way. Really, the key, I think the most important advantage to patients, and when they ask me what are the real advantages, I tell them it's the quicker recovery. That is the key, because the incisions matter in terms of their length of recovery. You can see this in comparing an open versus laparoscopic gallbladder operation, open versus endoscopic orthopedic operations. Go down the list. It has consistently been shown, it's actually a matter of surgical fact nowadays, that the size of your incision drives your recovery. The pain will resolve quicker with a smaller incision. It won't necessarily be less pain early on, but it resolves quicker because you have now incision in between the ribs. You're not cutting bone. Bone takes a longer time to heal. That leads to more of a long-term pain course. I think another important advantage is sternal infection. This is not a huge risk for most patients, 1%, maybe 2%. But if you're a diabetic patient, you're very keyed into your risk of incisional infection, and so you ought to know that there's an option that you can take that risk to almost zero. We are cutting in muscle, and muscle is almost resistant to infection. I say almost because it still does happen, but when it does happen, it's not such a major problem to deal with. It doesn't require repeat surgery because you don't have to debride dead bone like you do if you get a sternal infection. And that's really important nowadays because it's considered a never event. So-called never event by Medicare means that it's not reimbursed. So most of our patients are Medicare patients, being over the 65-year cutoff. And so that's really important. You have to have a strategy. If you have a high-risk patient, an obese diabetic, what is your strategy for trying to save your hospital from losing, $100,000, $200,000 a year for every sternal infection that you get? I'm going to have Dr. Schurlip come up later and give specific examples of how we've used the hybrid procedure here in the last 3 months. But the overview of it is that you can do it one of 3 ways. What we're talking about is combining PCI with surgery, and we can do it staged, where we do the PCI first. That's usually if the culprit lesion is in a stentable vessel. and then we do the surgery on the non-stentable vessels afterwards. The robot allows you to harvest 2 internal mammary arteries. So you can put the ports in the left, you can cross over to the right chest, harvest the right mammary, harvest the left mammary. Now, no sternum incision, so there's no downside to doing that like there would be in an open sternotomy case where there's a risk of sternal dehiscence or healing problems. Then I can graft 2 targets. We can stent the third. You can do that either way, PCI first or with surgery first. The advantage of surgery first is that that patient doesn't have to be in the OR on Plavix when we're doing the surgery, but in general that is a manageable risk for bleeding because of the lack of a large incision where there's a lot of tissue planes that are going to be bleeding. The way to solve some of the logistical problems of staging it is to do it simultaneously. And we have in development now a hybrid cath lab where we have surgical suite with a full fluoroscopy unit that is the same thing that would be in the cath lab, so we can do sophisticated cath procedures and surgery at the same time. I did my first case in February. We've done a total of 35 cases over the last 3 months. These have been relatively low-risk patients because they're seeking it out. They've saw the Arizona article, or they've heard from the internet of this option being available. And so their average risk of mortality is less than 1%. So that is important because when you're talking about outcomes, you got to realize that these guys are expected to have good outcomes. The way that we've been able to do a broader number of patients is by the hybrid approach. So now we don't have to just cherry pick patients that need 1 or 2 grafts, which is not very typical for the patients that are referred for heart surgery. Typically you need 3 grafts. So the way we can get around that I only have 2 mammaries, it's really only can comfortably do 2 grafts. Occasionally I would do 3, but that's a challenging operation. It's very lengthy. The way to shorten the case, make it a easier, more straightforward operation, is to break it down into 2 parts. Do the 1 or 2 grafts surgically, 1 or 2 stents by PCI, and then you've got a way to treat triple vessel disease in a fairly significant portion of those patients. We've done half of them with CABG first, the other half with PCI first, roughly. Although the majority of the patients are high risk, or low risk, we've done some high risk. I had a patient that had a previous heart transplant with an ostial LAD lesion that we were able to come in through virgin territory. Now the heart's stuck behind the sternum, so it's a very difficult reoperation in a heart transplant patient. He's on steroids. You don't want to be cutting a sternum open on a patient on steroids. So we don't have to do that. Come in through the left chest, virgin territory is what we call it, and drop the mammary off the chest wall onto his LAD. He hadn't had the mammary harvested because he had non-ischemic cardiomyopathy in the past, and the mammary was still sitting in its in situ position. Very easy operation, lasted 3 hours. Patient went home in 3 days. Other patients that were redos, like a patient that had 2 prior root replacements, and then a patient with a porcelain aorta. That's a very challenging situation with open surgery. But now if I'm using bilateral mammaries, I don't have to sew anything on the aorta. So I've got 2 in situ grafts that don't have to manipulate the aorta in any way. So it's not a very intimidating problem for a robotic heart surgeon to see a porcelain aorta or some of the other morbidities that complicate the heart-lung machine, the aortic cross-clamping, and the sternotomy risk. When you offer something distinctive to patients, what you see is that they're happy about that, and they'll actually reflect that in the Press-Ganey scores. This is important because now, as part of the HCAHPS measures, it's going to be value-based purchasing is coming, and that's going to be a big driver of the amount of reimbursement the hospital will get. We have performed fairly mediocre on that as an institution. The gray bars are the national averages for these various scores. Here are our scores here on a scale of 0 to 1.0, 1.0 being perfect, particularly with things like doctor communication, staff responsiveness, and those types of issues. With the robotic program, if you look at January to April for cardiothoracic surgery, the scores have been increased in those areas fairly sharply, over 10 points. And in things that you may not necessarily think that robotics would necessarily affect, like staff responsiveness. I mean, why would that change just because you're offering robotics? But I think it's just the fact that the patients have a better outlook about the hospital. I even found in Boston when we looked at patient satisfactions that the scores on the food went up with the robotic patients. So this is an example of where when you offer something distinctive, patients are going to respond in a favorable way. This is what I was talking about, the value-based purchasing. There is a clinical score, which is right now based mainly on just obeying evidence-based practice, the so-called SCIP measures in the OR, Surgical Quality Improvement Project, how you manage heart failure if you're using evidence-based practice. It'll eventually be about outcomes, but right now it's just about obeying evidence-based medicine. And then there's this satisfaction, which really is an outcome. That's an outcome now that they're monitoring. When we send out our Press-Ganey scores, when those scores come back, they're going to drive reimbursement. So if we look at how we did, this was calculated by the Press-Ganey software. If our value-based score, value-based program score is 30, which means on a scale of 1 to 100 that we would only get back 30% of our money. They're going to hold 2% of our total DRGs, which is almost $1 million. And that, we got to find a way to try to improve that. And I think that innovative programs is one way that, in my experience, you can do that. In addition to patient satisfaction, that's almost kind of a side effect of the program. I think one of the key advantages is the ability to use bilateral mammaries without any consequences, because now you're offering the patient a potentially better operation. There's a lot of debate amongst our field, is this an inferior operation? That you're going to be sewing grafts without having good visualization, without having good exposure. You're not going to be doing the same job you would if you opened up the chest and did an anastomosis on a still bloodless heart. Okay, so that we do these things for a reason. We open up the chest for a reason. Okay, that's one side of the argument. My answer is that the anastomosis is only one part of the equation for what leads grafts to survive a long time. Another, probably more important aspect is, are you using mammaries, are you using veins? So you can sew it perfect, but if it's a vein graft, it's going to go down in 5 or 10 years. You guys deal with those patients more than we do. We stop following them in 30 days. You know this better than the heart surgeons do. So we want to try to use conduits that are going to last a long time. And that's a much more important driver of long-term success, according to the literature, than is whatever technique you use to do the anastomosis, on or off pump or minimally invasive or whatnot. So even though all surgeons would accept as fact that bilateral mammaries are the best conduits to use, at least for your first 2 best targets, they're still very rare usage. National average as of 2009 at this particular report in circulation was 6% of cases. In Boston, they have a database that measures that closely called NASDAQ, and that's 4%. Here, because of the robotic technique, we've been able to drive our usage up in the last 3 months to 33%. So a third of our patients are getting bilateral mammaries, and that's because there's no consequence. We don't have to, obese diabetic with bad lungs, doesn't matter at all, because you can harvest them and not have to worry about sternal healing. It's not like you're going to get spontaneous sternal necrosis without an incision there. They'll eventually get collateralization of vessels and have a sternum that would be back to normal within a few weeks. 2 IMAs are better than 1. This is a title of a manuscript published by Bruce Lytle at Cleveland Clinic. It's been a kind of a landmark article, and several other papers have reproduced this data. But the bottom line is that if you take a young patient less than 65 years old, use bilateral mammaries, and compare that to a propensity score matched group of patients that have single mammaries, and then the rest of their targets taken care of with vein grafts, that you'll have about a 30% difference in reoperation risk, lifelong, and about a 5% difference in survival. So that second conduit after the mammary LAD does matter, and it should be another mammary. The cost. So we're doing technically difficult operations that have the chance of taking longer in the OR. OR time is very valuable. We're using expensive equipment. We are asking the hospital to market this program. These are all costs that add to it. The 3 main variable costs that drive the total bill are operative times. It's $100 a minute in the OR, which means $6,000 an hour. If your operation takes an hour longer, you're gonna ask your hospital to pay $6,000 more per case. The length of stay and blood transfusions are big drivers. The robotic program for the last 3 months, the patients that have undergone this, and again, these are low-risk patients, but nevertheless, we have not seen an increase in time. In fact, our times are less. Half of the cases have been single mammaries, and those cases are very short, 2.5, 2 hours, typical lengths of time. Now, the bilateral mammaries are 4.5 hours, so they do take longer, but it compares favorably to what we've seen in 2010 with the traditional CABG here at UMC. Length of stay has been cut in half with these patients down to 3.5 days, and it's unusual for patients to receive blood transfusions as compared to the majority of patients getting it with traditional CABG. So there are a variety of advantages here for clinical outcomes that are going to reduce the costs of this procedure. What I found when I compare the hybrid procedure, which is even more expensive than traditional robotics because now you have two sets of people involved. You have the stenting and the cath lab equipment and those disposables, and now robotic disposable equipment, is that intraoperative costs. This was my first 100 cases at University of Maryland where I first started this program. Intraoperative costs were up compared to off-pump CABG, which is the cheapest way to do surgery because you don't have to have a bypass machine. You're doing a full sternotomy and then just doing the bypass grafts on a beating heart. But then you made up those costs in the post-operative period, so that shorter length of stay, less blood transfusions, there was a significant reduction in the post-operative costs. So overall, it was about a wash compared to the two. What about outcomes? So we have an advantage in heart surgery when we're talking about outcomes because it's very clear what the list of things are that we're being judged by. It's not always the case for other surgeries. You know, you might say, well, what I think is most important is X, Y, and Z, and then what another person thinks is important is ABC. So here we have now publicly reported data that is clearly what we all ought to be paying attention to. And it's on Consumer Reports. That's when that actually happened last year. That's when this New England Journal article came out to document that this was kind of a landmark event. That now we actually have surgical outcomes published. You can go and look up Robert Poston and find out what my mortality rate is for my patients. It'll have robotic and non-robotic cases, and all the major morbidities. And here they are. These are the ones we're looking at: renal failure, surgical re-exploration for bleeding. Here's some process of care issues: risk-adjusted operative mortality, prolonged intubation, more than 24 hours being on the ventilator, deep sternal wound infection, stroke. Those are the morbidity and 5 major mortalities that they're looking at. I put stars next to these two because they're an inherent advantage of robotics. If I don't cut the sternum, I'm not going to get mediastinitis. And if I don't touch the aorta, I'm not going to likely have strokes because most strokes come because you clamp the aorta or cannulate the aorta, that dislodges plaque and lodges in the brain. That's the mechanism that's well established for why strokes occur. Occasionally there are watershed strokes from hypotension, but in general, it's embolic stroke occurring from the ascending aorta. Now, if you're not touching the aorta, no matter how bad the disease is, unlikely that that's going to dislodge. So we are already ahead of the curve with regards to robotics. So let's look and see how we've done here in the last few months. To plot this data, one good way to look at it is called a QSUM analysis. You look at the cumulative sum of the difference between your observed versus your expected rates of these adverse events, and then plot the patient number over time. So if you did 160 cases, you just plot it out over time, and then you'd see, you kind of track where the data are going. If you had higher rates than expected, you'd see the line start to go up. Each additional patient that had a complication, as you add your patients up, you'd start to see that curve deviating from 0. If you're exactly as expected, 1 out of every 20 patients had a complication, 5%, which is about 5 to 10% as expected, then it would kind of oscillate around this line. But if you had a higher rate, then you see a curve going like this. If you started to do better than expected, you start operating on some high-risk cases and they had good outcomes, your curve would go down. Here's what we've seen. It's almost a tale of two cities. Boston, I did 200 cases during my 2.5 years there. And here's again plotted 0 to 200. Looking at the cumulative rates of adverse events, starting out at 0, we saw 8 complications in the first 40 cases. That's a learning curve. That's the classic learning curve of having longer operative times and kind of figuring out what's the optimal case selection and those types of lessons that you learn. Then after figuring out some of those lessons and having a multidisciplinary approach to problem solving and trying to implement changes, we saw an improvement. Towards the end, we came back down to our expected results according to the STS database. The STS database has millions of patients in there, so we have a very good sense of what the risk should be for any given patient and the risk factors that patient has. So based on those lessons learned and perhaps some more surgical experience on myself, we have had a much different look as we've implemented the program here. We've had 2 complications, both re-ops for bleeding, and that has resulted in a curve that at the end of the 30th patient here is significantly better than the event. And there's certainly not that intense learning curve that we saw in Boston. The rationale here is to respect the patient's perspective. That's why we're willing to even tolerate a learning curve. The traditional way of going is an excellent operation. Okay, I'm not saying that we shouldn't consider sternotomy CABG. I'm just saying that the patient's perspective needs to be taken into consideration. They consider a ratio of the efficacy versus the invasiveness. Coronary bypass was invented with a strict, almost sole attention to efficacy, irregardless of invasiveness. You open up the sternum, you cut one of the biggest bones in the body to do it. You go on a heart-lung machine and stop the heart for an hour. These are highly invasive things to do, and so it was almost the ethos is I've heard during my training: big incision, big surgeon. You know, don't worry about this small incision stuff. But that has changed now, and it's changed because we now have a very competitive other option that, while you might debate its efficacy relative to CABG, even if it was less, it's right in the square of the patient's comfort zone. They would be happily willing to sacrifice some efficacy to be able to avoid coronary bypass. We've seen that again and again. If it's even an option for multivessel stenting, it's a safe assumption that you almost don't even have to ask the patient if they want to consider coronary bypass surgery. If they're technically feasible to do with stenting, you don't have to go through the details because virtually every time they will want multivessel stenting. I think that robotic-assisted techniques alter that algorithm a bit. I think now that we have a pressure on us as physicians to at least discuss this, because it starts to get in that gray zone between what is giving you the best efficacy and what is in the central portion of the patient's comfort level. They're going to have a surgery. They have to have general anesthesia. They're going to have the risks associated with any surgery on a guy that has coronary disease and perhaps other comorbidities. But they are going to recover faster, probably twice as fast as traditional coronary bypass surgery, and they're going to have the longevity advantage of the Lima to LAD. So with that said, I will let Molly take over with some case studies that we've done here. Sorry, I can't figure out this apple.
So even before Rob came to this university, I had been interested in hybrid procedures. In my fellowship, I had interviewed at a couple of places that had done hybrid revascularization, and even though I am an interventionalist and love to put stents in, there is definitely a place for this in that we all know that the Lima to LAD is a very fine revascularization approach, and that the Lima is a very good bypass graft. So when Dr. Poston came to interview here at this university, I was very excited because I thought that this would be the time when we could advance our program here at the University of Arizona and do something that no one else in the city does. So I've done 6 cases with Dr. Poston. I have 3 that I'm going to show today. What I have found is that it's, even though these patients were low-risk patients, their coronary disease was pretty complex, and what I may have seen from the coronary angiograms from outside institutions was not exactly what it was when I went in to actually do these procedures. So the first case is a 69-year-old who had a history of insulin-dependent diabetes. He presented to Dr. Poston for a second opinion. This is a guy who had a renal transplant, and he was on immunosuppressants, and he had undergone cath at an outside institution and was found to have triple vessel disease. He was very concerned about his sternal infection rate, given that he was on immunosuppressants, and he had heard about the hybrid approach, and that's why he came to see Dr. Poston. So the original cath showed a mid-LAD that was 80%, left circ OM that was 80%, and an occluded RCA. So these are his pictures from the outside institution. He had an LAD stenosis, which is seen right here. He had a circ stenosis right here, and then the occluded RCA. So he underwent hybrid procedure, and he received a Lima to LAD and then a Y graft using the REMA. Oops, I can't stop it. Let's see. Nope, I won't be able to play it. He had a Y graft that went to using the REMA to the PDA. So my part was to revascularize the left circumflex. So here's my opening shot, and this is the part that I was to revascularize. So using a 014 run-through wire and a BMW wire, I double wired to protect this area right here. We often do that so that if we stent across one vessel, we don't lose access to the other. Balloon the area and got what we call no reflow or slow flow down the vessel. You get this back by giving a lot of intracoronary nitroprusside, and the flow actually came back, as you can see here. I then had a trouble getting a 2.5 by 18 Xience stent, which is a drug-eluting stent, across this area, and so had to use some different techniques to be able to get the stent across. Used a special wire called a wiggle wire to help the stent across, and it was deployed. And so this is the final angiography of that case. Patient went home the next day after my procedure and has done well. The second case was a 64-year-old gentleman who came in with chest pain and shortness of breath. It was worse with exercise and improved with rest. His only coronary disease was 15 years ago. He had a PTCA, but really had not much follow-up as far as his coronary disease. He had type 2 diabetes, hypertension, hyperlipidemia, and was diagnosed with GERD. His troponin when he came into the hospital peaked at 9. His cath showed a distal left main ulcerated plaque, which involved the ostium of the LAD and left circumflex branches. He had a calcified left circumflex after the first OM with tandem focal stenosis, and he had a CTO, or a chronic total occlusion of the RCA. Now, if anybody follows along in the interventional literature, there's a lot of discussion on bifurcation left main stenting. The problem with bifurcation left main stenting in the distal left main is that there's a high rate of restenosis when you use bifurcation stents. And there's a lot of controversy as to when to put 2 stents, or when do you provisionally stent. You stent across one of the vessels and hope the other one doesn't close and whatnot. So this is actually a good procedure, a hybrid procedure to do, where he can put the Lima to LAD, and then we can go in and stent across the LAD and not worry about the LAD going down because it's being protected by the left circumflex. It's being protected by the Lima. So I always check his grafts first, and you have to be careful when you do this because in the first couple of cases, there's a lot of edema. It takes a while for the Lima graft to mature, so you may see a lot of swelling, and it doesn't mean that there's a bad anastomosis or anything like that. It's just recovering from surgery. So this is the Lima to LAD. And then, if you notice here, he has an ulcerated plaque that goes in the distal left main and then involves the two branches of the LAD and left circumflex. When I originally decided to do this case, I was going to attempt to also stent what appeared at the time to be focal stenosis here and here in the lower portion of the left circumflex. But my main priority was to make sure that this large OM was protected. So as I do with a lot of these cases, I do something called intravascular ultrasound, where we can actually look inside the artery. And I IVUSed the left circumflex, and my IVUS wouldn't go any farther than here. He was very calcified and fibrotic at this point, and I couldn't go any further with the IVUS. And if you noticed on angiogram, that area did not look so bad from the eye, which is why we do a lot of IVUS, because the arteries often look worse on the inside than they do from angiography. So I used multiple inflations with a 2.5 by 12 Voyager balloon and got this. And I actually could get a balloon down in the lower part of the circumflex, but it was very tight getting across this junction. So at that time, I decided that it was probably a better idea to at least take care of the upper portion of the circumflex that protected that OM, and to not worry so much about this, which gave off very small collaterals. So that was after inflation again with the larger balloon. And then we put a 3.0 by 18 Zients, which went to here. IVUSed again, post-dilated with a 2.5 by 12 and a 3.0 by 12 non-compliant balloon. Had put a 3.0 Zients right here, and then post-dilated that to a 4.0 vessel. And so if you look at the final angiography here, the plaque is gone, it's tacked up, and there was a nice result. The last case that I'm going to show is an 81-year-old gentleman who came to us because he had a abdominal aortic aneurysm repair with an aorta bifem. And while he had this surgery, he had a non-STEMI post-op, and he was found to have a reduced EF, with I believe his EF was between 20 and 30%. So he was referred for coronary angiography. Now, about 60% of my practice is actually radial approach. And so for him, because he had 2 surgical scars in both groins, I did him initially radially. So his left heart cath showed an LAD with a very long mid 80% ulcerated plaque. The left circumflex was okay. His ramus intermediate was a fairly large vessel with an 80% stenosis. His RCA had an 80% at the bifurcation of the PDA and PLB. Given his low EF and his triple vessel disease, he was referred by the primary team to Dr. Poston for a hybrid procedure. In this, he underwent a week after his hospitalization. So initially, when I did his original diagnostic cath, I went in his right arm. And when I had to go back, obviously, we have to take pictures of the Lima. It's much harder to go from the right and then cross over to the left subclavian. So I had to go through the left, which was a little bit more difficult in that he has this really tortuous radial artery. But we managed to get up and get over. And this is a picture of his lima. He has a lima and to the LAD, and there was a lot of washout, so it was kind of hard to show this picture. But there's a lima to LAD and then a Y rima to diag. So this is his RCA, and his stenosis is right here, right at the crux. It was about, an 80% stenosis. So once again, we double wired, ballooned the area. Got a fairly nice result. Placed a 2.5 by 12 Xiant stent and post-dilated it to 2.75. And this is his final angiography on that side. And then we proceeded to his left coronary system to tackle the ramus intermediate branch so that he would get a full revascularization. IVUS, the intermediate branch. Once again, he had a lot more coronary disease than what was initial on angiography. Multiple inflations with a 2.5 by 12 balloon. Placed a 2.5 by 28 Xiants here. So it went down to here. And then a 2.5 by 12 Xiants right at the ostium of the ramus intermediate. And this was IVUS guided. Post-dilated the proximal portion to a 3.0 vessel so that we wouldn't impinge on the left circumflex. Remember, the LAD is protected, so I wasn't too concerned about covering the LAD, but wanted to make sure that I wouldn't cover the left circumflex. And then IVUS at the end. And so this gentleman, so all of these gentlemen had full revascularization, using the hybrid approach. All went home within 3 days of their procedure and are doing remarkably well. So, if you have any questions. Yeah, Boyer, Dr. Boyer.
So, obviously, not having a sternotomy is a big deal. So, the patients who cannot, first thing is the patients who could not undergo this approach would be, what kind of patients would have to have a sternotomy as opposed to those? It's a little unclear to me, especially now that you can do multiple vessels, both interventionally and surgically.
Yeah, no question that interventional techniques expand the number of patients that are candidates. It's one of the things that's been a problem with this program is that you're just looking for these patients that just have 1 or 2 vessel disease in order to be able to treat them robotically. And then so you don't get the practice. So the key to who you should and shouldn't do is who's it safe for to do robotically. If it's not safe, you shouldn't do it that way. So the patients that have instability, either in terms of their hemodynamics or active angina, ongoing ischemia coming up to the OR. Those guys you're not doing a favor by avoiding a sternotomy. A sternotomy in that case is going to be the safest way to go. The reason why is that under traditional circumstances, you have to come to the OR, do a sternotomy, a guy that has active angina or active problems, that's going to make it worse. But quickly you're going to be on a bypass machine and you're going to be safe. With robotics, we come into the OR, we do a lot of things before we're in that safety zone. We have to do a double lumen endotracheal intubation, is a little bit more complicated than standard, so that we can deflate the left lung. That can cause a little bit of rise in CO2, a little bit of drop in SATs. That can exacerbate pulmonary hypertension. We've got to manipulate the heart by insufflating CO2. We've got to harvest 2 mammaries, which can take longer than harvesting one with an open chest. And so all those things extend that time prior to a heart that is not happy being protected by the heart-lung machine. And if you're doing it off pump, the safety time is when you put your graft on the heart and reperfuse. So either case, you want to be careful about people that are not stable. Low ejection fraction, if you need to graft anything other than the LAD, is another one. You don't have, sometimes these guys have basketball hearts that take up their entire left chest. I have tried in the past to get to targets on the back, like in the first case Molly showed, I grafted the PDA. That was in a very small heart that I could rotate the heart around and make an incision right here, put a suction cup on the apex of the heart, and then pull the heart around so that the PDA is presenting in my wound. But if the heart's a basketball, you can't do that, no matter what you do. So that's another example of the
What's the advantage of doing it simultaneously as opposed to sequentially?
Well, if you're doing a really complicated case, I prefer probably to do distal left mains that are really bad. I mean, that guy that I showed, his distal left main was bad. You know, he probably could have been done simultaneously. We got away with it. Just because to know that he's right there and can do something if I get in trouble is the nice thing about doing it simultaneously. Also, instead of having to wait 2 days, I mean, it probably cuts down on hospitalization because we would do it at the same time. Once he recovered from his thoracotomy, he could just go.
It's kind of the best experience for a patient to go under anesthesia and get it all taken care of, not have to go back for example. But there's some other things. If it was difficult to do some of these stents, and I'm lucky to have an interventionalist that's aggressive and experienced with doing these difficult lesions that she kind of got a little bit surprised by in the OR. She's now participating in triple vessel disease, which is a much more virulent disease than the single and double vessel disease that interventionalists have dealt with in the past. So if she wasn't successful in one of those cases, and we did it as a staged procedure, now I got egg on my face because I've done an incision over here, and I may have to end up doing a sternotomy to take care of it. So you know, I'm fortunate that these cases worked out. But that's one of the things that we might run into with a staged approach that would be solved by a hybrid strategy, simultaneous.
If mammaries are so much better than venous grafts, why do most patients get venous grafts? The mammaries are there whether you do it sternotomy or not. Why aren't more arterial grafts used?
Yeah, 6% of cases, according to the STS database, are using bilateral mammaries, and it's because it's a risk for sternal infection to take both mammaries off of your sternum.
In the face of a sternotomy.
Yeah. If you don't have a sternotomy, there's no risk.
Just a comment, very nice, excellent presentation. That's the big issue with two mammaries for an open chest because the VS is almost a fatal disease if you can't treat it. Subsequent. But I think this strategy opens up a new chapter, but I still think we need to kind of work out some of the bugs because the issues are going to be some of the technical issues as far as anticoagulation.
Yeah.
One of the things I was going to ask you before you got into this whole point was the issue of we're being more aggressive with antiplatelet therapy today. So traditionally surgeons are leery of that. And what's been your experience with as we go to stronger and stronger antiplatelet agents moving from clopidogrel to prasugrel? We believe, for us as interventional cardiologists, it's a good thing because it keeps stents open. But it may be more of an issue for you.
I'm sure it will be.
So, quick comment on that.
Plavix seems to be okay. The cases that I've done on Plavix, we have had anecdotes of patients that bleed, but in general, on average, the patients with minimally invasive surgery bleed about the same as they would with just aspirin alone. Now, prasugrel I've never operated on, and the data that's out there is just abstract presentations at AHA and ACC that I've seen have suggested that there's a dramatic increase in bleeding on those patients in those trials that have had to, for one reason or other, go to heart surgery on prasugrel. And in fact, there was some evidence of maybe mortality rates being because of bleeding. So it's a very worrisome drug for that purpose.
So I think the thing that has to be worked out is going to be the anticoagulation strategy for the true hybrid, because that's one of the issues with bringing it back versus not. Because you really want to have maximum anticoagulation as much as you can tolerate.
Yeah.
It doesn't hurt us, but if you go with lower level, it may compromise.
Well, aren't most of the, if you could tell me this better, but just for the sake of argument, aren't most of the more potent antiplatelet therapies for the people with acute coronary syndromes, not necessarily the ones that are getting more elective type PCI?
If your clinical risk is high and your acuity of regurgitation is fine, and your angiographic risk is fine, those are the patients that, those three risks, those are the patients that truly need, for instance, the 2B3As. But if you don't have that high risk, not. But, I mean, the point that I'm getting at is that surgical strategies that were more open, clearly had CTs that were way up, you know, because you're on bypass, you know, 4, 5, 600, those types of things. We haven't used an ACT. Traditional angioplasty was an ACT of 300. The last time we used an ACT greater than 220, probably, you know, Molly, in your training, you never used an ACT greater than 220 because we wouldn't, in today's world, do that. So I think that's the type of thing that we have to get tight to do a very good simultaneous hybrid strategy. We have to figure that out.
In the larger case studies, the one that I'm thinking of, I guess, is Vanderbilt, since they seem to be one of the first who have done it and has the largest. So they do most of theirs simultaneously. And what they try to do is, if it's easier cases, they'll have the surgeon go first and then give the Plavix. If it's harder cases, then they'll give the Plavix right at the time, right before intubation, and let the interventionalist go, because even in our literature, that's okay, you know, to give it on the table.
Sure.
And they have sort of that 3-hour window, you know, and it seems to be okay.
Yeah, I agree with that 3-hour window. What we're talking about is if you load the Plavix up in the operating room, down an NG tube, then you've got 3 hours before that takes effect, and you can get your operation done. And then once hemostasis occurs, these drugs, these antibiotics don't provoke bleed. It's not like streptokinase where you spontaneously have bleed. So actually, you know, I've given loading doses of Plavix immediately post-op and not had a problem.
And I tend to use heparin and not Angiomax, just because it's longer. I mean, the Angiomax would be harder to reverse.
Yes, sir.
With the robotic